Good morning.
Good morning.
Nice to see you.
You too, Carolyn.
I'm hoping you're well.
I am. I'm very well, thanks.
And so am I. And, well, here we go with, with our wonderful questions
All
that
right.
we always get. I'm going to start out with one that we wanted to start off with. So I'm going to start off with it. Dr. Rosenzweig, we've talked about this before, and we have many times. However, there continues to be just a lot of confusion behind this. Could you again please go into detail about what exactly estrogen and progesterone does for our bones? Mainly progesterone is what this woman is talking about. Most doctors say that estrogen is the really important hormone for our bones, but they never say if P is important or not. Usually they say that it's not, especially if you've had a radical hysterectomy. There's a second question to this about testosterone, but we'll ask that in a second, if you don't mind.
All righty. It's a great question because bones are a big deal. And when you look what happens to women as they grow older and older and older, and men, is bone loss is almost epidemic. And there's reasons for it because what matters to bones undergoes a major hit in midlife because hormones matter to bones greatly. And there's a lot of hormones that matter greatly to bones. Yes, estrogen is very important. And so are several other hormones. And of course, in our book, Happy Healthy Hormones, which you can download the PDF version of right off the Facebook Ins and Outs of Menopause, we have a chapter on bones. It's so important. And a gerontologist lectured to our class when I was a senior medical student and made the comment that I mentioned many times on our Facebook Live, but it's so important. He said, "You're senior medical students. You know thousands of diagnoses. Let me tell you what's really happening to elderly. They're losing their bones and they're losing their muscles, and because they lost their muscles through sarcopenia, they cannot stand and walk with stability. They fall on their osteoporotic bones, fracture a hip, and die." Back in the 60s, that was a very common thing. Now with surgery, women may be living, but not that much longer. So bone loss is a big deal, and it's not a possibility, it's a probability. Midlife on, the likelihood that you're going to lose bone is very, very high. There's
Is it
so many moving
silent?
parts. Pardon?
Is it silent? I mean, is it like that silent kind of
Yeah,
thing?
it
Or?
is silent. You don't feel the bone loss, but it is occurring,
Yeah.
and we can see it on X-ray. Of course, we use a special X-ray called DEXA scans to really assess them best. And oh my God, do we see bone loss on DEXA scans? But radiologists can see bone loss on a chest X-ray, and we'll comment on it from time to time. So hormones play a huge role in bone health. Like estrogens, for example, really affect the cells that are related to bone health. Because we think of bone as very stagnant and very stable and but it's not. It's very metabolically active. We have a recycling process going on in our body. For example, probably every red blood cell that you had 3 days ago is no longer there. It's been replaced by new red blood cells. Your old red blood cells are broken down, recycled, and new red blood cells are created in your bone marrow. Well, every tissue and organ in the human body has a replacement rate. Bones is about 7 years, so it's a little slower. But what's going on with all of our bones at all times is there's cells that break the old bone down. They're called osteoclasts. And there's cells that lay the new bone down. They're
Right.
called osteoblasts.
Right.
And what estrogen does is it slows down the activity of the osteoclasts. So bone does not get broken down as quickly. And when you have no estrogen, that bone gets broken down at such a rate that within a very few years, we can see the bone loss on special evaluating techniques. If we measure your urine, if you're midlife, we can see bone metabolites showing up in your urine. Yeah, they always do because there's an active metabolism there. But we don't want to see too much bone metabolism called DPD or deoxypyridinolone. We don't want to see that too much of that stuff in your urine. That means you're breaking your bones down too fast. So to prevent the excessive breakdown of bones, you want adequate estrogen. If you don't have that adequate estrogen, it's not a possibility that you're going to get osteopenia or osteoporosis. It's a very, very, very high probability. It's almost a guarantee. That's a big deal.
It's a very big deal. I see
And
it.
because I've worked with the elderly, including my elderly mother-in-law and my elderly mother, both of whom fractured many bones, this is a real thing. And so many women are in rehab in nursing homes because they have fractured their hip. If I fell down or you fell down on your hip right now, it's very unlikely you're going to fracture that hip. But anyone who's got significant osteoporosis, it's very likely that they're going to fracture that hip or fracture any other bone that they fall down on. Like my mother-in-law, bless her heart, when she was alive, she fractured her shoulder and her pelvis from a simple fall in her kitchen because she was a little unstable on her feet. In her late 80s, she fell onto a tile floor, was in rehab for 3 months. This is a very real thing. And sarcopenia, the loss of muscle, I know that's not part of the question, is so critical. I think one of the most important things that we do when we replenish hormones for women is we replenish their testosterone. Because without adequate testosterone, you're going to lose muscle. This is not like a maybe. Take a look at the thighs of elderly women. If you see them walking on the Florida beaches, which you don't see a lot of, those thighs are thin. Same for elderly men. They're getting sarcopenia as well, loss of their testosterone. It's a big deal. That's what leads to the instability, and that's what leads to the falls, and that's what leads to canes, walkers, and wheelchairs. It's that sarcopenia, that muscle loss. And man, when you transition from walker to wheelchair, for a lot of folks, that's assisted living. That's leaving your beloved family home and moving into an assisted living facility or a nursing home. Back to bones. Progesterone affects bones. It's the only biochemical I know that supports the function of the osteoblasts that lay down new bones. There's a medical doctor in British Columbia, Geraldine Pryor. You can look her up. She's done a lot of the research here.
Yes, I have that down. Carolyn Pryor.
Carolyn Pryor, yeah. And, progesterone had this funny thing happen to it. So there's so many misconceptions about it. One thing we know in young women, that young women have 100 times as much progesterone in their body as they do estrogen. Gee, you think maybe, quote, nature, end quote, had a plan for progesterone? And
Uh,
you name any hormone in the body, these are our most powerful biochemicals that we got going for us. Any hormone. And if you look at any and every hormone, they have multiple functions. They function everywhere. They function in the nervous system. Progesterone calms down women who get anxious in the perimenopause, so often anxious to the point of feeling wacky or feeling crazy. Oftentimes, and they're put on anti-anxiety or mood alterers. No, give them progesterone. Some of them will come completely back online. Dramatic stories we have of that. Progesterone's the great calmer. Progesterone works all over the body, just like every other hormone does. But the misconception that occurred is one of the functions of progesterone is it balances estrogen.
Right.
And we want them in a nice balance. Well, for example, estrogen stimulates the formation of the endometrial lining, the lining to the uterus, which is what you menstruate, what a young woman menstruates. Well, if a woman in menopause is treated with estrogen alone, and she has a uterus, even though she may not be on robust dosage, she's liable to form an endometrial lining and menstruate or bleed. However, if she's given proper amounts of progesterone, which balances the effects of estrogen, that will contain the formation of that endometrial lining, and it's needed. We need to suppress that endometrial lining. So the misconception that came into practice is many women have had hysterectomies. Oh my God, don't get me started.
Don't get me started. I'm one of them.
And what I mean by that is, with all due respect, a lot of those hysterectomies were not really needed. If someone really understood hormones and stress, and a lot of those hysterectomies could have been prevented just by proper hormonal treatment. Oh, proper treatment with progesterone. Oh, that'd be at the vanguard of anything I would think of to prevent excessive bleeding, which is the cause of so many hysterectomies. Because a woman's progesterone can fall off and diminish and decline earlier and deeper than a woman's estrogen. So the woman doesn't get the balance. She can do some heavy bleeding there, and that's been the cause of so many hysterectomies. She can develop fibroids. That's another major cause of hysterectomies that can be prevented by proper treatment with progesterone. Well, because not a lot was known about progesterone 50 years ago, 30 years ago, the belief is that a woman had a hysterectomy, she no longer needed any progesterone at all. Don't treat her with progesterone. So it's so common when you listen to people who care about treating women properly, but don't necessarily know enough about hormones because they haven't specialized in it. You'll hear comments right and left almost everywhere you go. Not everywhere. More and more people are learning this. They say, well, you've had a hysterectomy. You don't need progesterone. Wrong. You need progesterone. 100% of you, not 99.9% of you. Well, I want to caveat that. There is a certain number of women out there, it's a small number, that have special sensitivities for progesterone for a variety of reasons. And they need special care in discovering proper progesterone dosages. And a lot of it's because, as I picture it, that their progesterone fell off so early and the progesterone receptor sites went dormant that it's a work of art to get a woman who hasn't seen enough progesterone or any progesterone for a long time, how to get her on progesterone and do well with it. So it's usually these women who've had these early hysterectomies or women who have special sensitivities to progesterone. That's another subject. So that's why I wouldn't say 100%. There's some women we really have trouble getting them back on progesterone for different reasons. So I'm going to say 99.99%. You need progesterone. Love it. Embrace it. And not only that, when a woman has bone loss, osteopenia, osteoporosis, we get super aggressive with the progesterone. We'll gradually increase progesterone dosages with the hope of alleviating some of progesterone deficiency symptoms, such as sleep disturbance, mood disturbance of small, medium, or humongous magnitude, sleep disturbance, mood disturbance. We'll keep on increasing the dose until a woman says, wow, I'm sleeping again. Now, there's other reasons for sleep disturbance. That is for sure, including estrogen deficiency, but I'm not going to dive all the way into that. And what we'll do with a woman is we'll give her progesterone primarily at night, and we'll keep, she got osteopenia, we're going to push that progesterone dose as high as we can possibly get it. And we're not concerned about it because you look at the medical literature, you don't see bad stuff about progesterone. It doesn't occur. You don't see it. I'm very familiar with the medical literature around menopause, and you don't see problems with progesterone. And think about it. When a woman is pregnant, her progesterone levels skyrocket. So she's already got 100 times more progesterone if she's young and menstruating than she does estrogen. And when she gets pregnant, progestation, promotes pregnancy. Oh boy, does it. It skyrockets. So a woman's body can really handle a lot of progesterone. Well, a woman with osteopenia in menopause will gradually increase that progesterone dose at night. That's the best time to take it because it can really help with sleep. Some women, we have them also take progesterone during the day, especially if they have mood issues. But most women, they take their progesterone at night. And progesterone is the big calmer, the great calmer. That's why it helps with sleep. Many women in pregnancy get super calm. Progesterone is the great calmer. So if we give a woman too much progesterone at night, she gets too calm. And how that shows up is she wakes up in the morning and she feels groggy, like she's got a hangover from as if she had taken an excessive dose of a sleeping pill. So a woman with osteopenia, we're going to help titrate them right on up to where they wake up the next morning groggy, and then we'll back them down. We'll back that dosage down. Why am I saying this? Because anyone with bone issues, we want to be maximized and optimized, which is the maximal dose of progesterone, among other things. There's a chapter on bone, once again, in our Happy Healthy Hormones. But one of the things we want to do is maximize that progesterone. So there's some thoughts about progesterone, and there was a side question there about testosterone. I want to just talk about it as it relates to bone and muscles. Testosterone is important for bone. Thyroid's important for bone. You name a hormone, they're important for bone. Most of them. So bone, like everything else in the human body, is a lot of moving parts. So we want to address all the moving parts if a woman has bone loss, including we want to assess her properly. Like when, for example, when we see osteopenia, that means bone loss, on a DEXA scan, a bone scan, we look at this from many angles. One thing we do is we test her urine to see if she's putting out excessive amounts of bone metabolites in her urine. That means she's got too active a bone breakdown process. So we want to discover why would she be doing that? Well, the classic reasons are she doesn't have enough estrogen, she doesn't have enough progesterone. And then we go to, does she have enough testosterone? Does she have enough DHEA? Does she have enough thyroid? As far as hormones go. Then we go into diet and gut health. So that gets, we describe this in the book. We go into digestion. Is she digesting the nutrients that bone's made out of? Or is her urine too acidic?
Yeah.
Because the body knows how, the body does not tolerate excessive acid in the bloodstream or bathing the cells. It's
Right.
got an exquisite and intense regulatory process to not be too acid and not to be too alkaline. And it uses many tools it's called buffering excessive acidity.
Yes.
Someone's got excessive acidity, the body takes measures to reduce the acidity. Well, one of the main measures it takes is it uses minerals to counteract the excessive acidity. Where does it get the minerals? In the mineral bank account called bones, because the bones is made out of minerals. That's one of the main places it grabs minerals. So we deal with excessive acidity as well. Oh, stress biochemistry is acid producing. Oh, there we go again. Stress and bone loss. Oh, some diets, very common American diets, or should we call them the common American degradation diet? Because if it ain't organic and if it ain't natural and if it ain't got a lot of vegetables in it, it's an American degradation diet.
And it comes in a box.
In a bottle and a can.
Yeah, plastic bottle. I'm sorry.
No less.
No less. A question did come up that I'd like to present. It says, how can you best help yourself in perimenopause and menopause without taking hormones, especially anxiety?
I'm going to give you a radical answer that
I know you are.
be politically correct. I don't think it's possible not to have the level of health you really want. I mean, there's a
No.
lot of things you can do for your health. My God, you can really tune up what the food you eat, the breathing you do. You can tune up your exercise, so crucial for your health. Oh my God, to get exercise correct. It's one of the most potent things anyone can do for their health. Do the right amount of exercise, not too much and not too little. The common error is too little. And the elephant in everyone's room is how skillful are you at dealing with the stress in your life? Stress is natural in human life, and it's needed. However, the issue becomes if you're not skilled at dealing with the stress and you get all freaked out, for example, and you trigger the fight or flight biochemistry,
Right.
that's a problem. So the remedy, the medicine is acquire the information, tools, and support to get super great at your own emotions, your own mind, the choices you make, the courage it might take to make alterations in your life, to communicate, for example, when things are not going well and you're afraid to communicate. I mean, there's a lot of things that'll trigger that fight or flight response. So there's tremendous basic health promoting choices that are great because they're just terrific all on their own. And they're going to do a great deal for you. And many women have not replenished hormones in the menopause at any time. And there's a rare instance where they're doing well, where they're thinking clearly, where they're physically active, where they're able to stay at home. But you don't see that too commonly. Assisted living facilities and nursing homes are loaded, packed to the gills, primarily with females who've had to leave home. And as we've been talking to colleagues periodically, like I asked a medical doctor yesterday in our grand rounds that we do with our healthcare providers, I asked a very knowledgeable, wonderful doctor, Dr. Sawyer in Naples, Florida. I'm going to name names. I asked her what percentage of the women that, and also a nurse practitioner, I asked this too, to Liz, what percentage of the women that are in assisted living facilities do you think are there because of low hormones in nursing homes? Now they gave an answer that was really radical. Both of them said close to 100. So I'm not going to agree that the way to go is don't replenish hormones. I'm going to say it matters greatly. It's one of the most important things you can possibly do. And not only that, you want to get it right. You want to get the proper amount of estrogen, the proper estrogens, the proper way to take it, which is topical, the proper carrier, which is our organic oils. You want to get the proper amount of testosterone. Oh, yes, you do. It's not a male hormone. It's a human hormone. So
Well,
crucial for women.
I'm sorry, in this question, which is interesting to me, she says, can men's FDA gel be used for ladies too, but at a lower dose?
Well, I'm not going to advocate a method that is not my favorite. We deliver testosterone, we dispense testosterone, we write a prescription for it, and we dispense it in the organic oils. I'm not a fan of gels. But if that was the only tool we had, and we could test a woman to make sure that she's not taking too much, because the male testosterone is usually very potent.
Right.
But the only tool I had, I would say, yeah. But
Okay.
that's not. You want to go to a healthcare provider that really understands testosterone, really knows testosterone dosage, knows the proper carrier, knows how to administer it to you, and knows how to test your testosterone levels. How do you test? 24-hour urine hormone test. I challenge anybody on this planet to tell me that there's another way to get that one accurate. I know there's a lot of other methods out there, but I'm not going to agree with it unless someone can demonstrate to me that there are not problems with the other methods, as in small, medium, or major. But 24-hour urine hormone test is fantastic because ultimately we want to confirm when a woman's on testosterone that she falls within the optimal zone on 24-hour urine hormone testing. It's really important.
Optimal being the optimal word, right?
Yeah, not too
Yeah.
little and not too much.
Right, because a question just came up saying, I'm really afraid of testosterone. I don't want acne, hair everywhere, a deep voice. So
Well, you're
can
not going to get acne, hair, or deep voice if
right,
the dose is properly.
correct.
But I can tell you, 100% of women, not 99.9%, by 3 years into menopause at the latest, are super low in testosterone. I've never seen an exception. Maybe there is one. Most women these days that we test, they're low in testosterone in the perimenopause because they've over recruited their testosterone for the biology of the stress response.
Yep,
And they've just pushed their adrenals and their ovaries too hard for too long.
right.
So it's very common. 25 years ago, I used to see more women who at least went into the perimenopause and menopause with adequate testosterone, maybe even a bump up, but not these days. Man, women we're testing. And you don't have to, you don't, I can just, in our questionnaire, when we're asking a bunch of questions about women, like for example, a woman, if you're on the floor, can you get up without using your arms? Can you do a squat? You getting any cough incontinence? How's your libido? There's a lot of indicators. You got any flab in the triceps area here? If you do, you lost triceps. How'd you lose triceps? Inadequate testosterone. So it's very rare that I run across a woman in the perimenopause or menopause who's got adequate testosterone. And yeah, you want to get all the hormones balanced. You don't want to just take testosterone.
Right.
You know,
Right.
Carolyn, there's some interesting additional questions that have
Yes,
shown up.
there are.
Do you want to ask those questions from Sean and also from Sylvia? Let's start with Sylvia.
Okay, well, Sylvia has said a couple of things. We were talking about progesterone, and she says, I'm opposite. I believe she said, I'm opposite. Progesterone makes me feel like I'm crazy. My anxiety gets so bad. And she also says, what about women that take progesterone and they start having depression symptoms? What causes this?
Well, this is once again expressing a massive need for right dosing.
Right.
And the women who get depression on progesterone, in my experience, most of them are on an overdose for their body. So it doesn't matter what dosages are common or what dosages are out there. Progesterone, that women can get a depression on progesterone, but it's usually because they're on an overdose. So there's no limit to how low we can go. I mean, with what we have in the organic oils, like the most common progesterone that we prescribe is 200 milligrams per milliliter, and we'll go up to 40 milligrams topically when we use it topically, or 50 milligrams at night. Well, geez, I've had women that we did progesterone 5 milligrams per milliliter. Holy mackerel! That is 1/40th the most common dose. Why do we go to 5? Because if we gave her too much, she would get depression. But
Got
if
it.
we give her the right amount, she did not get depression.
Got
Now, we're
it.
talking about a rare situation, Sean, but it's not rare if it's happening to you, you know? So that's called very, very, very significant. So, but this is what the call is for. You want to work with someone who really understands these things and really knows how to work with and test you for the right amount. There are some women who have some special progesterone sensitivities, and that's a subject for the experts. So if you have had an adverse response to progesterone, we know that that happens. There's paradoxical effects that can happen from anything we give anybody.
Yeah.
But your job is this. Don't throw progesterone out the window as not good for you. Your job is find someone in your state, because now with telemedicine, you just need to find someone in your state who's licensed in your state that is really good at this, that's taken on treating women in menopause as a specialty, that's acquired additional information and tools and mentoring and support, and has really embraced getting menopause right. That's your job. If you have a special progesterone sensitivity, don't give up on progesterone. Find someone who really knows what they're doing.
Well, if it's any consolation, just for me, it took me about 5 months to really balance out well. I had to be patient, and I was anything but patient, but I learned how to be patient due to this wonderful man here helping me do that, and my doctor. Um, yeah, but it is doable. Really, it is. Um, there are other questions that are coming up, but I have other questions here. Which way do you want to go, Doctor?
Let's go to the ones that you already wanted to ask.
Well, um,
We've got an early stoppage today too. I've got
oh,
a commitment in 14 minutes.
holy moly!
Time to fly, 12 minutes. Oh my goodness. It's imperative that I stop. Actually, I need to stop in 7 minutes. Yes, I apologize, but we're going to be on again next Tuesday. And
We will, and
we'll
we're just
as
going
we
to
always
hold this
do.
one piece of paper for the next 2 weeks and answer all these questions. Oh my. Well, let me see. Let me see. The one question that did come in first was I'm waiting for the results of my 24-hour urine lab. I did have a doctor tell me that both my estrogen and progesterone are low, but they are balanced. And she says, balance is the most important. Yes, as I'm working my way up.
Oh, this is not a 6 minute question.
Okay,
6 minute
next.
answer. No, but let me take it on, Carolyn, because it's a great question.
Okay.
Um, there's so many ways to assess whether your hormones are too low. And I'm going to make a wild guess that your doctor used blood testing to tell you that your hormones were too low. Well, once you're taking hormones, if you're taking hormones, the test that works to assess your hormone levels is the 24-hour urine hormone test. Blood testing is fraught with complications. Like, when did they draw your blood compared to when you took your preceding dose? Because if that was a while, those hormones could have come and gone. So I'm not going to, my opener to answer this question is I'm not exactly sure that your hormone levels are low. The way I get to know whether they're low or not in many women is just asking a series of questions that tell me whether you have symptoms of low hormones. Now, that's pretty strong evidence. If you got symptoms, for example, a woman's having hot flashes, it's so unlikely that there's anything going on but low estrogens. Now, there's a rare instance where she's overdosed with estrogen. That sounds funny, and an explanation is needed for that. But when a woman's having hot flashes, she's low in estrogens. unless she's on overdose. Well, if I know what her dosages are, I can also predict that. So symptoms tell us a lot. And 24-hour urine hormone test really tells us. So I'm not sure. And then there was a second part to that question, Carolyn. What was that?
Well, she said that the her E and P are low, but they're balanced, and
Yeah,
she's
okay,
saying
balance.
balance is important.
I've
Correct?
heard this concept around balance, and
You have?
I'm going to look at it an entirely different way. That
Okay.
every single woman needs the optimal amount of estrogen for her
Okay.
and the optimal amount of progesterone for her.
Okay.
And there's no numerical mathematics that can tell me about balance. Because let's take a young, healthy woman. There's some women that have really rich, robust estrogen levels, and they're healthy. And these women sometimes have very low progesterone levels, relatively speaking. There's
Yeah.
other women that have relatively low estrogen levels, relatively. They're still healthy, they're fertile, they're having regular menstruation. They don't need as much estrogen, but they have relatively high progesterone levels. And there's everyone in between.
Mm.
So when we're working with dose determination with estrogen and progesterone, we're working with them independently. There is no mathematical balance that I can say, well, if you do 2 drops of the estrogen, then you need 4 drops of the progesterone. No way. If you need X milligrams of bias, then you need you need Y milligrams of progesterone. No, we work with them independently. It's not hard. We even see this in the body type of young women. Now, this isn't an absolute thing, but if you see some woman who's real tall and thin and sort of straight body type with small breasts, this woman loves progesterone. She's got a very high progesterone output and not necessarily a robust estrogen output, but she can be perfectly healthy with her internal balance of estrogen and progesterone. If you see a woman who's short in stature, very curvy, large breasts, she's very rich in estrogen and can be extremely healthy and fertile and have regular menstrual periods. She may be quite low in progesterone, relatively speaking, but she's going to have enough progesterone if she's ovulating. So this even shows up in the body types, this balance
Tall,
between estrogen
short.
and progesterone. My main point is don't go by math. There is no math that, to me, in my best opinion, that predicts what balance actually is. So, but we don't need it. We get the estrogen doses right by a process of titration and confirmation by 24-hour urine hormone test, and we get the progesterone levels right by a process of symptom titration, alleviating symptoms of progesterone insufficiency while backing down from symptoms of progesterone excess if we go too high. That's how we determine these levels, and we confirm by testing.
Well, thank you very much. I see the time.
It looks like we've got, yeah, the time. The time has happened. It's fun, Carolyn.
You know,
Time
it
goes
is
quickly
Dr.
when
R, and wow-e. I am very excited, and you know why. Yes. So, geez, Louise, holy mackerel, and all of that stuff for everybody. I so wish everyone was wise like this Dr. R. I had to say that to you. I'm always complimenting you, Dr. David Rosensweet, always, because you're wonderful.
Thank you,
And
Carolyn.
we all love you. We do. So I'm going to wish you a very, very good weekend. I'm going to wish all the ladies a very good weekend. These questions, those questions, I'll get the screenshots, we'll answer them, and we'll all have a good time getting well. Yeah?
Sounds good, Carolyn.
Sounds good,
Yeah, it's a
Doctor.
pleasure to do this with you.
Always. Yes, we've been doing it a long time,
Yep.
and we're going to keep on going. So Have a
Okay,
great
so
day.
until next time, everybody.